Well, thanks everyone so much for joining us today for this webinar on an expert's view on cross-border clinical negligence. As many of you who've watched our webinars know, or by speaking to me, cross-border clinical negligence is something that I think needs to be on all of our radars, whether you act for claimants or defendants. And we're seeing a huge rise in medical tourism. It's something that's being spoken about a lot in the press at the moment, whether it's patients who are struggling to get seen in time for a hip replacement on an NHS waiting list who are then going abroad, or whether it's people going abroad for cosmetic treatments or surgery, is something that I think we all need to be alive to in this particular area of practice. Now, today I'm absolutely delighted to be joined by Fulvio Urso-Baiarda, who really needs no introduction, but I'm going to give him one anyway. He is an award-winning consultant plastic surgeon who completed his doctorate at Oxford University and has over 20 years of experience working in private hospitals around the world. He often acts as a medico-legal expert, and some of you may recognise his name from the recent High Court judgment in the case of Clark and Kalasinski. If you haven't read it, it's a must-read if you specialise or want to specialise in cross-border clinical negligence, and he was the medical expert in that case. Now, before we get chatting, just for those of you who are joining us, I'm sure you're all Zoom veterans and know exactly how this is going to work. But just a few rules, if I may, at the beginning. If you have any questions, then please do pop them in the Q&A box. And what I should say is that this is going to be an open discussion. So we're not going to be going through a number of slides. It's going to be an open and interactive discussion. I'd really encourage you to take the opportunity to pick Fulvio's brains and to have a chat with us about these cases, because I think it will be invaluable to you all. But if you have a question, just pop it in the Q&A. If you do pop it in the chat, I'll try and look out for it. But sometimes it gets a little bit lost. So if you can with the Q&A, that'd be much easier. And also, please don't use the raise hand function, just because I don't know why you're raising your hand. It doesn't tell us, unfortunately. So again, if you just pop a comment in the Q&A, that would be much easier. But Fulvio, thank you so much for coming. It's a pleasure to have you.
You're welcome, Dominique. What an introduction. Thanks very much.
You're welcome. You're welcome. For those of the people that are joining that don't know much about you, would you mind sharing a brief overview of yourself and your practice?
Yeah, sure. So I trained as a doctor many, many years ago at Oxford, and did my sort of normal kind of medical stuff, my medical pathway in various rotations. But I think I honed in on plastic surgery very early on, about 2002, I think was. So I did sort of nothing other than plastic surgery since about 2002. That took me as a trainee through many units in the UK, which is kind of nice because I know a lot of people and a lot of plastic surgeons in various places. I sort of know them directly or indirectly, and culminating in various fellowships, an aesthetic one in London, observership in New York, which was an award that was given to me by the British Association of Aesthetic Plastic Surgeons, and then qualified. And I became a consultant. A lot of my training had specialised in microsurgery of the head and neck and of the breast. So I was a breast reconstructive and a head and neck reconstructive microsurgeon for a number of years. And I was working in a fairly busy small unit that did a lot and punched above its weight. So I found myself doing lots of things. My first day as a consultant, I had to put 4 fingers back on, which is quite unusual actually to have to, and they all lived. So that all lived and worked afterwards, which actually is maybe more surprising than you might realize. So that was day one, and that was a birth of fire. I carried on doing that for a while, and actually for various reasons, and I think intrusion into sort of what we can do in the NHS really, and loss of freedoms, I became fully private a few years later. Being something of a control freak, I set up my own clinic quite quickly, and I really just wanted control of the environment and the processes, and have been doing largely aesthetic work since then. I went from mixed reconstructive and aesthetic to largely aesthetic, and now for a few years I'd say my practice has been 95% plus aesthetic. By virtue of that control freak tendency, and we were just chatting before we joined in, the latest venture is actually a fully fledged inpatient general anaesthetic theatres hospital, which is currently being constructed not many miles away from us. So that's what the future has in store now.
And you did some work as well, if I'm right, in Sierra Leone. Is that the case?
Yeah, that's right. Yeah, so that was before I was a consultant and after I was a trainee. So there's this kind of fellowship period, and which in my case was thankfully quite long, because I got the qualifying exams to become a plastic surgeon quite soon, but I wasn't time expired as a trainee. So you're then a fellow, and in that time you can sort of have fun. So I did more fellowships than might be usual. I did 3, plus an observership, which maybe counts as a 4th. And in that time as well, I went off to Sierra Leone, doing some limb reconstruction there as a result of the civil war that was there. One of the ritual punishments for people who voted wrongly was arm amputation, and including in children. And I've met, I've met young adults in their 20s who were pre-teens or teenagers when their arms were amputated as a form of punishment for voting in the household. So there was an awful lot of it was an eye-opener, I can tell you. And
I'm sure.
I could give a talk if you catch me for drinks one time. But the talk rapidly becomes quite an emotional one. I mean, the things that we saw there, I'm fairly changed forever, and just the most wonderfully upbeat, positive people I could meet. So yeah, that was something as well. That was an eye-opener.
Yeah, absolutely. Well, what a career. And you've got experience, obviously, of doing work abroad. And so, today we're focusing on cross-border clinical negligence. So when people go abroad for surgery and unfortunately things go wrong. And I just wondered, from your perspective recently, have you noticed any change, any increase or decrease in the number of people that either attend to see you that come from having surgery abroad and are seeking some second opinion or reassurance?
Yeah, it's an interesting one. So I think I'm slightly unusual in the sense that I've been seeing a large amount of overseas referrals for a long time. They seem to find their way to me, and I end up doing corrective work, not infrequently, and have done for quite a few years. And I think maybe my name got out there in that sense. So I haven't personally noticed a huge upswing in that. It was already quite significant, but I have noticed a difference in the amount to which my colleagues are talking about it. So I'm sure you are, plastic surgeons are part of WhatsApp groups, and we all communicate with each other. And there are some fairly comprehensive WhatsApp groups in which you can put the word out to pretty much every other plastic surgeon in the country if we want to. And there's an awful lot of chatter about cosmetic tourism at the moment, more than I'm used to seeing. There are databases being set up now nationally by the British Association of Aesthetic Plastic Surgeons. There's real resurgence of interest. So it has got me thinking, this is sort of spilling into mainstream practice now. So my perception is that it's something that we are all seeing a lot of now.
Yeah, absolutely.
Although I can't say it's more common in my practice than it used to be.
So with the databases that you were mentioning, what sort of research is going on about it? Is it the quality of the care abroad, or, for example, so we've seen recently with the FCDO about the number of deaths abroad from medical tourism of British nationals in Turkey. So is it akin to that?
It seems to be trying to capture a snapshot of activity at the moment. I honestly don't know how they're going to crunch the data later. This is being managed by BARPS, and I haven't been in part of that project. But they are capturing. They want to know what activity is being seen. They want to get us an idea of the frequency of referrals amongst all its members, and the nature of the nature of what the surgery was, what's gone wrong with it.
That's really interesting.
It will be a great resource.
Yeah, absolutely. And in terms of, I know you said obviously that you've dealt with this sort of way, dealt with this cross-border element to your practice for some time. Has the nature of the complications changed in terms of the particular surgery? So, for example, were you seeing more BBLs or breast surgery gone wrong, and has that picture now changed?
Yeah, I was exactly going to say that. I used to see more BBLs.
Oh, right.
I actually used to see more BBLs, and I think Brazilian butt lift, so lipofilling to the buttocks. It used to be a really popular operation, and it just exploded. It was the Kardashian effect for a while. Then there was a run of mortalities, and it was considered the procedure with the aesthetic procedure with the highest mortality rate at 1 in 5,000, which is astronomically high as a mortality. And if you look into why there is such a high mortality with those cases, there are good anatomic reasons for them. But BARPS took a decision, I think it was 2019, I believe, if I remember right, that it recommended its members don't do it while it was being researched.
Okay.
The BARPS member, right, that's it, I stopped overnight. Now, there were a few patients out there, and the word got out that it's illegal to have a BBL in the UK, and it's not illegal at all. It was a BARPS recommendation that its members don't do it. Even BARPS members could still do it, and non-BARPS members, there was no kind of ethical dilemma. If they felt qualified to do it, they could continue to do it. So it wasn't illegal, but it was the amount that it was offered in the UK did decline greatly. And a lot of us had concerns that would drive patients overseas, actually.
That's really interesting. I wondered if that's what I was going to ask, actually, if that you think maybe a reason behind it.
Our big concern was that it would, and for a while I think it probably did, but superimposed on that, there was a general downturn in the number of patients asking for the procedure overall. So it went from being the sort of, I don't want to say anything offensive, the sort of Jessica Rabbit, I can say Jessica Rabbit because she's a cartoon, the really overemphasized buttocks were something of a flash in the pan, and they're no longer, certainly in the UK anymore, they're not as desirable a thing as they used to be. I and I think many of my colleagues are fairly cautious about complying with something that just looks like a fad, just looks like anything that you won't look back on fondly in 10 years' time. We shouldn't really be doing now either.
No.
So bodies aren't pieces of disposable fashion. You're stuck with your body. But they did, thankfully, there's not the same demand for them. So I'm seeing fewer of them. Now, what I am seeing, but I think this has been across the board for a long time. I'm seeing a lot of augmentation mastopexies. Mastopexy combined with augmentation. But back when I was a trainee and I was starting to think about how I would embark on my practice, I was being advised by my senior colleagues that is the thing that gets you into trouble. That's the hardest aesthetic procedure, certainly the hardest aesthetic breast procedure. So I guess I'm not that surprised at that one.
That's quite interesting. And in terms of the complications from that, what are the most common complications you're seeing from those patients who've had that abroad?
With implant-related surgery at all. So it seems to be the common themes tend to be poor preparation and poor aftercare. And the surgery itself can sometimes be a bit mediocre in an artistic sense. You look at it and you think it's not brilliantly, it's not an inspiring result, but it's done the job. And if you're not massively it's fine. It's okay. But the things where things go really wrong is aftercare, and catastrophically wrong. And it's patients trying to access care in an urgent situation after surgery and not being able to, or accessing that care, and the sort of cues aren't there. There's often delegated care. And with my UK practice, actually, where things seem to go wrong most, it's when there is delegated care, which can be fine, as long as there's a mechanism of escalation. And if there isn't a mechanism of escalating a concern, maybe at dressing clinic level, nursing level, to a surgeon for surgical intervention, that's where things seem to go really badly wrong. So infected implants not being treated, hematomas not being evacuated, broken down wounds not being addressed, implants being left to heal, things that just won't work.
And for quite a lot of us who deal with these claims, we often see that someone's booked a package holiday, for example, which has a couple of nights in a hotel after the surgery, and so they seem to be discharged almost immediately from the hospital, perhaps say within 2 hours or so, and then they go to a hotel to recover. And I'm assuming that causes a number of problems in terms of the aftercare that they should have, because it's not a sterile environment.
Yeah, it's difficult actually, because when I'm providing an opinion as an expert, I'm very, I try to stay aware of the range of practice rather than what I think is great. And it's, it's all very well saying what you do and isn't that wonderful, but it's actually what is an acceptable range of practice that's most useful to you. And there is a range of acceptable practice when it comes to discharge. Day surgery is becoming much more common, much more fashionable. And if you are in a central London environment, you're much more likely to find yourself in a day surgery setting for surgeries that certainly outside the M25 you would have an overnight stay for. So I'm relatively conservative in that sense. I'll keep breast augmentation. My patients at the moment stay in one night. That may not be the case even in 2 or 3 years' time, but currently they stay in one night. This facility we're making has inpatient beds because that is simply what's expected in this region. But in London, similar facilities will absolutely be day surgery ones. So when you think about being discharged from a hospital setting to a non-sterile environment in 2 or 3 hours, well, that's very common in the USA. It's very common in central London. And so I'm not intrinsically critical of that as long as the care package is appropriate, as long as the patient is adequately recovered.
So I'm assuming then that if they've got, say, several appointments scheduled thereafter to check in with their surgeon, make sure everything's healing as it should, then that's not too much of a concern. It's where there's a complete breakdown of that, or they don't see the surgeon afterwards and get on a flight home where things have gone a bit wrong and have an infection.
Or they try to review them but fail to do so. But I suppose thinking about the environment, because you said they're being discharged to a non-sterile environment. Well, of course, a hotel is non-sterile, but actually an inpatient room is non-sterile. It's not an operating theatre. It's at that point, it's a sort of residential accommodation kind of thing, admittedly with nursing care. And it's extremely clean. It's in a hospital setting. And there are standards that, we are regulated by the CQC, whereas your local hospital isn't. So you have got quality control measures in place, but the level of the level of cleanliness of a hospital room is very clean, whereas the level of cleanliness of a theatre is, surgically clean or sterile.
Yeah,
they're not quite the same already, and
sure.
a defence would reasonably argue on that a well-maintained hotel room can be similarly clean to a well-maintained inpatient room.
And in terms of flights, I often find it's a point that's often raised. Should someone within, say, 2 days or 3 days then be allowed to get back onto a plane and fly home? Because often it's something that we see in these cases. Do you think that there is any specific time frame in which they should not fly, for example, shortly after the surgery? Because often we see, I think it's usually about 48 hours, but sometimes it may be more or less in the circumstances. But there's just, of course, a concern about blood clots and things like that is often crossing our minds.
Yeah, there really is. And then you look to the range of practice and you just see confusing variability, and it sort of tries, it blows consistency and a consistent approach out of the water. So I'll start with what I do. That's easier. I ask my patients to stay in the country for a month after their surgery. Not because I'm concerned about DVTs actually, but because a month is when you're pretty much into clear water with the likelihood of even a medium-term complication like a seroma. So I would rather they were locally available, so that if they have a complication, I'm dealing with it, not some other healthcare provider in some other country. However, that's absolutely not mandatory. If you think about DVT risk, you look at the NHS guidelines for that, and they would say that superficial surgery, the DVT risk, following superficial surgery, the DVT risk tails off, and I think it's something like 4 or 5 days after the surgery. So flying after a week would be perfectly reasonable, and quite probably sooner. Most of what we do would be considered superficial surgery, actually. Then you go to the hospital providers in the UK, and again, there's variability of practice. So many recommend you don't fly for a month. because of DVT risk, and they just take this sort of blunderbuss approach, whether you've had superficial surgery or deeper surgery or more invasive or whatever. One, so Spire, that I know of, and I only know this because I work at Spire, Spire insists that its patients don't have a flight a month before and after surgery.
Interesting.
Right. So there's a whole 2-month period where patients being treated at Spire can't travel. And if you then go into the basic science of it and the rheology, which is the study of blood viscosity and likelihood of clotting, indeed, if there is a period of stasis before your surgery, it primes you towards a greater risk of blood clots. So you can sort of argue this any which way, and I revert to what is considered acceptable or reasonably prudent practice. For me, it seems to come down to the duration of surgery. So someone having a 1 hour, 1.5 hour breast augmentation, they've been lying still for about the same length of time as you might sit in the cinema. So I think their risk of blood clots is actually materially not greatly affected by surgery like that. The surgery itself affects your likelihood to clot by causing you your body trauma and a stress response. But again, the stress response from relatively minor surgery is probably quite low.
Yeah.
So there's that level of surgery at one extreme, which I think is actually, you can reasonably take a view that flying quite soon afterwards is fine. On the other hand, if you've had a total body lift and you've had a 6-hour procedure and you've had a multi-site combined procedure, then your DVT risk is quite high. After about 4.5 hours, your DVT risk starts to shoot up. And at that point, I'd be very much more cautious about long-haul flights. Are they wearing thromboembolic stockings for the flight? Have they been given heparin injections if they have to fly? Has something been done in terms of mitigation? And I think crucially, consent is the issue, because if a patient says, okay, I'm aware that these DVT risks are higher because I'm acting as a cosmetic tourist and I accept those increased risks, then I think that mitigates against the practitioner somewhat. Whereas if there's absolutely no awareness given to them, then it's another matter.
So is that something, when we're looking at consent processes, you would expect to see something mentioned about DVT risk wherever the surgery was happening in the world?
Yeah, I really would. DVT and deep venous thrombosis and pulmonary embolism are, I think it's fair to say, at the last 2 words of any general anaesthetic consent form I write. And I think most of us write. That there is the principles that guide most of us in terms of giving consent are: we need to warn patients about anything that's either likely or serious. And thromboembolic events are serious and actually not that vanishingly unlikely either, like under 1%, but
Sure.
not rare. So I would say, they're mandatory.
We had a really interesting question from Victoria Cox, who hopefully is with us today. And she asked, are there any international standards when it comes to plastic surgery that practitioners in all countries should adhere to?
Yeah, so if that question is using the word should, then yes. And if it's using the word must, then the answer is no.
Okay.
So yes, there are international bodies of plastic surgery, things like the ISAPS, the International Society of Aesthetic Plastic Surgery, Aesthetic Plastic Surgeons, and they have a framework of acceptable practice, and it is an international body. But it's not mandatory to be a member of ISAPS. You'll find many really highly regarded, reputable, good practicing UK-based surgeons who are not members of ISAPS. I happen to be, but I wasn't for my whole consultant practice. I joined maybe 3-4 I think years ago, and when you then look at their code of conduct, it's all couched in shoulds as well. Okay. And there is no real sanction. The sanction against breaches of ISAPS code of conduct is dismissal from ISAPS. Your membership will be barred.
Sure.
So making that a sort of legally enforceable, yes, there are guidelines and they can be used to support your case. The international guidelines should mirror the national ones, and we will all be members of a national body, so they should be quite similar. But I am struck by variations in practice around the world. I mean, I could tell you about the consent. I photographed the consent form in Sierra Leone, actually,
Sure.
because it was another time, but it was appropriate for that environment. It was an environment in which the level of education was generally quite low. The level of knowledge about healthcare was really very low, and there was a very old style patriarchal system of healthcare, which is, it used to be the UK one decades ago, but is no longer, thankfully. And the consent form said, I, and the name would be pre-written, agree for the doctor to do what they think is right, and you just sign.
Oh, wow.
or put a cross if you couldn't sign.
Yeah.
So, and that's a perfectly functioning kind of healthcare system, which seems to be okay in that setting. So as long as the fundamental principles of providing healthcare, and we can you sort of have to go back to Hippocratic ethics at this point, are adhered to, then that might be okay.
Gosh, I still can't believe that's what it said.
That is. I photographed it because it absolutely blew my mind, and it was the case after case, patient after patient, that it was the same consent form, and they would sign it. Now, as healthcare providers in that setting, you see that, and your knee jerk is immediately so, can't do this. That's not right.
Yeah.
But at the same time, we were very aware of going in and trying to change a system that was not our system to change.
Sure.
And being respectful of that, and you can still provide good healthcare in that setting. It's just the way you communicate it.
Definitely.
So I'll give you an example. Within the first few hours of arriving, we found a 12-year-old. I talked about amputations. Unfortunately, this is an amputation we did. A 12-year-old boy who had chronic infection of his bone, osteomyelitis of his bone, and was moribund. And he required, as an emergency, an above-knee amputation on one side. And that consent form was the consent form. Now, it doesn't mean the discussion was that. And it was very much a discussion of, right, this is what's going on. Here is your x-ray. That's what it shows. This can't be treated, and we know this. The treatment to make you feel better is an amputation. Obviously, you know that an amputation will have great impact on your quality, on your life. It's a life-changing event, but I think it's necessary. Please go away and think about it, but please don't think too long. Went off 24 hours. Now the consent form actually didn't reflect that conversation. The notes did, and we wrote in the notes what the conversation had been and the discussion. The consent form was just do what you think is right. X.
It's really interesting. I was going to say, we've just had another comment. This is from Roy Donnelly, and he sent one in advance. It's just reminded me, don't worry, Roy, I was getting to you. He has asked, Fulvio, if you can comment on the risks of provision of remote medical advice from the UK to doctors and patients located overseas.
Yeah, so it's a minefield, and I'm sort of I was interested by that question because it's a direction of travel that I'm not aware of happens so much, or maybe I just don't become aware of it. But remote practice is fraught, and remote practice across jurisdictions and across country is fraughter, if that's a word. As doctors, we're a conservative bunch. I found a fax machine in a medical museum in Cyprus that was the same model fax machine that was in my NHS office. So, we are technologically quite a behind group as a group.
Sure.
And I think COVID changed all that, and things like this, Zoom consultations, remote consultations, we were all talking about it for ages, but it never happened because we were all worried about confidentiality and data storage and everything. We are an incredibly conservative group of practitioners. And then it got brought in, and culturally it's now acceptable in healthcare provision because it had to be. And but a lot of those concerns were valid concerns. So things like, will the technology work? Is it confidential? Can I store it? So the whole nuts and bolts logistics side of things. Also, if it allows you to communicate across big distances, does the healthcare provider actually have jurisdiction in the location at which the advice is being received? So I'm registered to practice in the UK, but I'm not registered to practice in Spain. So if I am giving advice, what is my legal status there? Am I practicing legally because I'm based in the UK, or illegally because it's being received in Spain? So there's all sorts of minefields there.
Definitely. I mean, what I usually see in my cases, and obviously anyone watching, you can chip in to say what your experiences are, but I often see that practitioners from other countries do road shows either in this country, and so they may have a day where you can meet one of their surgeons and ask questions, or alternatively, people may be told through social media, well, you can meet one of our clinicians on WhatsApp. And often I've had cases where there's someone from the clinic who's the translator, as it were, trying to communicate between the two on WhatsApp video, what the patient wants, and to ensure that's provided. But I think we've had this conversation, Fulvio, before about how do you know whether something's truly been lost in translation or not, or whether you've really understood, or the practitioner's really understood what someone wants if they're doing it by means of a WhatsApp consultation, as it were.
I'm really, when a translator gets in between, my level of anxiety goes up a lot. And in my personal practice, the only time I've had an outcome that I've looked at and thought, that's just fantastic, I'm really pleased with that, and a patient who's been saying in a language I don't understand, making angry noises, and you just think that there is some mismatch here, and I think it can happen so much more easily. That was fairly early on in my career, and at that point my heckles were raised by being interposed by a translator, and I'll really do anything I can to avoid it if I possibly can. Bear in mind that aesthetic healthcare, aesthetic surgery, aesthetic medicine, whatever it may be, this is non-urgent care. This does not need to be provided by someone who cannot speak your language in a situation in which there is no translator or an inadequate one. And I'd say ideally, have it provided by someone who speaks your native language, or who speaks your language well, where there is no perceived communication barrier, and just get away from that whole thing. You don't want to put yourself, either party doesn't want to put themselves at the mercy of the adequacy of their translator, and by definition, neither of them will know how good that translator has done.
No, absolutely. Particularly in the cases I deal with, I often see it's just someone from the clinic who happens to speak both languages. So they're not a registered translator to that, or anything to that effect. It's just they're trying to do their best to facilitate. Then you do wonder, well, how on earth do you know what someone wants? And then it doesn't surprise me when we see a poor outcome case of someone saying, well, I haven't got what I asked for, because you think, well, you go back to the initial consultation and look at what happened there.
Yeah, what was really asked for. And almost worse is the relative who speaks both languages, because then there is the potential overlay of conflicts of interest. And does the relative, maybe it's a husband, does the husband have an outcome that they consider more desirable than the patient, which they're communicating on their behalf?
Yeah, that's something I didn't think about, actually. That's an interesting issue. But I had another question for you, if I may, Fulvio. Appreciate, of course, you were in the Clark case I mentioned earlier, and Mr. Justice Foster said about your report that it was couched in such stringent terms that your conclusions covered any surgical and indeed clinical practice, whether governed by local Polish customs or standards or not. And when we're, as lawyers, looking at standards of care in these cases, and even when you're looking at these cases, where do we draw the line as to whether that act or care wouldn't be acceptable anywhere, rather than that there's just a difference in custom or practice? Is there anything that we can look to that you would say, well certainly that's got to be a massive red flag here?
Yeah, I think that's a really, really difficult one, actually, because where do you draw the line? I think I'm just going to frankly say I don't know.
Sure.
Sorry, there was a quote somewhere that I'm sort of struggling for, and if I get it wrong, it'd be really awkward. But I think there was a judgment once about whether something was art or pornography, and in stating I think the ruling was, you know it when you see it, and when something is so far across wherever that line is that it's sort of sprinted past it and kept going, you know it when you see it. And that case for me was quite astonishing. I'm not one who will give, massively bullish opinions, and this is dreadful and that's awful and you can never do this and it's utterly, and someone so much as uses that caliber suture, it's absolutely dreadful. It's really not where I'm at, and I really do try to consider a range of practice and try to think, okay, is something, if it's at the fringes of a range of practice, then it actually probably is acceptable to a responsible body of practitioners. But when something gets so far beyond that, and in the detail of that case, there were repeated instances in which a patient, the patient, returned to the clinic in the subsequent days after surgery with signs and symptoms that were indicated an infected breast implant, that any of us who deal with this kind of surgery must know. You must deal with that emergently. And I wasn't so, in my report, I wasn't so bullish that I said, right, the first time someone sees this patient, they must get them into theatre and take the implant. I didn't actually say that. My view was, well, at that time point when they first presented, there were signs that were enough to either admit, observe, give antibiotics, review the next day. But they were not. They were sent home. And it was reliant on the patient for themselves to reattend, which they did. And at that point, their symptoms did actually mandate a return to theatre. And I think on that day, again, they were sent home, or there or thereabouts. Then another opinion was obtained, and they were given oral antibiotics. So there was a recognition of an infection, but what was wholly the wrong management for an infected foreign body, which cannot be, a 3-day-old infected foreign body just cannot be managed in this way in someone who is septic. And then further reattendances, and then the patient is seen not by a delegated surgeon, but by the original surgeon, and they were told that they were wearing the wrong size garment, which was causing their discomfort, and that they had a low pain threshold. To which my response in my report was, there is no amount of ill-fitting of a garment that will give you fever and chills. No. So these are fairly objective things that were clearly wrong, and any surgeon anywhere who puts an implant in should, I believe, know when they have suffered a complication that requires it to be managed, including by removing it. And I think it's a really well-established principle that surgeons need to be able to manage the complications of their surgery and not just do the operation. And that's clear to me.
It's a bit like the elephant in the room, isn't it? Because I had a case a while back where someone was booked to have surgery in Belgium, was picked up from the airport by their surgeon, who then handed them a consent form in the car to say, read this, sign it, and I'm going to be operating on you as soon as we get to the hospital. And they felt they had no time to process what on earth any of it meant. Of course they didn't, but I'm assuming it's something like that, where you look at it and think this can't be right on any level, that someone could adequately process all what was about to happen by being picked up in the car half an hour before an operation.
I mean, the stuff that I encountered doing this kind of work has just utterly astonished me. And, patients having much prolonged operations and then being anaesthetist going home, being firemen's lifted into the back of a surgeon's car, waking up, on their sofa, surrounded by kids running around, drains falling out and things like this.
Oh my goodness.
Utterly astonishing.
So was that in the surgeon's home? They've been taken to the surgeon's home?
Yeah, the surgery, not small surgery, an abdominoplasty in this case, conducted in a GP practice by, a rent by the hour anaesthetist. And
wow.
I don't wish to say surgeons because they weren't, but 2 people conducting the surgery, and they literally being taken, spending the night. Oh, and then they got billed an extra amount for an inpatient stay that hadn't been factored in, an inpatient stay on their sofa.
I mean, that's what I tend to find with these cases. I don't know about you, compared to clinical negligence cases in this country, is that when things go wrong, they go very, very wrong. Not to say that there aren't instances here, but it's of a totally different level, I find.
Yeah, I've seen some pretty shocking stuff in the UK as well. I mean, who knew that Heathrow Airport could be the location, that a hotel in Heathrow Airport could be a location for surgery, but apparently so.
Oh, really? Oh, we've had another question of someone, it's more of a comment, but saying, just a thought, I think that doctors should be contacting their MDOs before providing medical advice virtually to people that are abroad. I'm assuming, Fulvio, from the converse should be true. Maybe the standards of care are different abroad, I'm not sure, but would you expect that if someone is giving a consultation remotely, say a surgeon or a doctor from abroad, that they should be checking that they're able to provide that advice to someone who's in another country?
Well, now that you ask the question, I'd say defensively, you're probably right. But I also think back, and so part of my practice involves remote consultations. I have some patients who travel from various parts of the UK, at least, to have their surgery with me. And you have a scheduled consultation. It's 6 weeks after surgery. You want to just check in, check all is well. And Zoom pops up, and then you look at, you're chatting away, and you think, weather's nice there. Like, oh, yeah, I'm in Dubai. And you think, oh, right, I've been provided. So I honestly, I actually don't know what the rules are around this, and I think we could do a clarification on this. Does the appointment confirmation have to say, by the way, please let us know if you're outside of the country and we need to check if this is okay? I don't know the answer. In fact, I'd be grateful if anyone there does know the answer and can tell me. Please let me know.
I don't think there's anything that I know of universally or globally that we should all know about in terms of that process, because often we see it in these cases that there's a WhatsApp consultation or there's some sort of FaceTime call or something, because one party is located abroad and the other isn't. So it's quite common. I haven't seen anything yet to say that they shouldn't have had the consultation in that way, but it's an interesting area for sure.
Yeah, well, I mean, in where one could, I'd say, innocently fall foul is where you book, for instance, a patient of mine last week lives in Norfolk. So rather than coming back from Norfolk for, driving for 3.5 hours for a 10-minute wound check, they had a supervised wound review. This is now several weeks after their surgery, remotely. Now, if they had taken themselves across the ferry to France, where I am not a registered practitioner in France, would I be in breach of rules? I don't know the answer, but it's I think recommendations need to catch up with the new world, because the way that we practice and the way that we communicate has changed, and borders are broken down, but jurisdiction isn't. So
Definitely.
I imagine there could be some interesting cases in the next few years.
Definitely. We've had a comment from Barbara who's asked about our views in a case where a client has a consultation abroad and the view on the problem or diagnosis is different. And she says she's got a client who had a second opinion abroad and the diagnosis is different to that in the UK. Now, I don't know what your thoughts are, Fulvio. It's not, in terms of what I've seen with these sorts of cases, I tend to find sometimes, I've seen it in a context where someone has had surgery in this country, they felt it was negligent and have gone abroad because they wanted corrective treatment and someone's told them they can fix it, and she's made it 10 times worse. So I've seen it in that context, but I haven't got any cases that come to my mind of where they're just providing two different opinions.
Well, it's in going back to the previous question, because it relates to this. What are the challenges of providing advice overseas? One of the big ones, I didn't think I finished, but one of the big ones was that you may just not have access to all the records, and communication is more difficult. I'm often having to reach out to GPs, often repeatedly, because when GPs receive letters from an aesthetic plastic surgeon, they often file them in the bin, I think, or file them in the notes and never look at them. Just the same thing. So I'm often having to say, no, I really, really do need you to engage on this one sometimes. And some, the fact that we have potential access to direct hospital records, to pathology records, and so on, with the patient's permission, really helps. Now, some of these difficulties can arise where someone goes overseas, and often all you have to base an opinion on is what's there on the face of it. So the facts of what is presented to you. And that's where things really can fall apart. And that communication is, there are obvious examples, like if someone has had a breast lift, for example, and they need a redo breast lift, where was the pedicle originally? The pedicle being what's keeping the nipple alive. Because if the pedicle is designed from above, and you now come and design your pedicle from below when you're re-elevating it, then you have no pedicle. You've circumferentially completely cut around and undermined this nipple, albeit at 2 stages. So that level of knowledge is important, and that's an instance where not having that could make things catastrophically go wrong. And it's really easy to presume an inferior nipple pedicle, for example, because that's all you see around you with all your colleagues, and that's normal and established. But in other countries, it's not normal. Even in other units, it's not normal. So, yeah, not having access to the records can really make things fall apart. And I'm skeptical of these sort of sweeping second opinions without all the facts. And it's one of those situations of no lack of confidence in the face of not having all the facts at your disposal. Just make me worry.
Definitely. I know that in quite a few of my cases, one of the key problems has been that it's never the treating surgeon board's never requested, or the clinic had never requested the patient's medical records. And I always worry there that how do they know that they're a suitable candidate for surgery? How do they know that they've got the full information and facts just on the basis of a short questionnaire that they filled out? Because someone could decide to conceal some information from them, for example. And how can you just trust what's given to you rather than assessing the background to check that that's accurate?
Yeah. So it's a fair point, but actually it's a fair point that affects us here too.
Sure.
And like I say, when I write to, so the way I structure my consultations, they're always two preoperative consultations. The first one is kind of fact finding, working out where we're going, what is the operation actually going to be? And then there's a pause between the first and second, during which you can send a load of information, consent, documents to prepare them for the consent conversation next time. At that first one, it's speculative. That patient may choose to come to me, but they may not. And I don't need to bombard GPs with every kind of speculative inquiry. So at that point, I write to the patient, but I don't write to the GP after that first one. Now, if they come back for a second consultation and we've really got intent, we're on this pathway now, then at that point, I'll say, right, I really do need to communicate with your GP at this point. And at that point, after that consultation, I request information from the GP.
Okay.
9 times out of 10, I hear not a word, absolutely nothing.
Not really?
That's been a real change in UK healthcare. And I think GPs are absolutely under it. They are, all hands to the pumps. And I guess I'm not surprised, but I don't hear back. And we went through a phase of really being quite, hey, we haven't heard back from you, and chasing it up. And now we do take a no news is good news approach, especially as our own waiting lists are so long that, we know that it's not an administrative process. It's not just lost in the post. There really is nothing. In a few cases where we've got genuine focused, directed concerns, we'll pick up the phone and just ring GP and say, look, we really need to know something here. But most of our patients appear well. We've done our own mental health assessments. We believe they're well prepared for it, and we will often take on trust what we're told. So I don't think that's a problem that is, and that can be abused. And one of the features of body dysmorphic disorder is some level of sophistication at concealing your illness. I've got a funny anecdote on that one. I'll come back to in a second. But yeah, so it's something that affects all of us. Okay, the funny anecdote. I was asked to provide a report on someone who had eyelid surgery. And it turns out they had eyelid surgery and then had a complication of it, in that they developed an ectropion. So they developed a sort of a lower pull and some exposure of the lower lid. And it turns out they'd previously had the same surgery years ago and hadn't told their surgeon this.
Oh, wow.
They had body dysmorphic disorder. And it turns out the surgeon actually, in that case, and I didn't provide a supportive report for the claimant. I was approached for the claimant and I didn't provide a supportive report. And I said, actually, the surgeon, and there are well-documented efforts to try and elicit this information. There are questionnaires, it was really well-written records, which actually were defensively extremely useful for the surgeon. And this was clearly a patient who, it turns out, did have a long established history of BDD over many decades, who had denied that, who had denied the previous surgery and so on. And this complication would have been much less likely in a primary case than a secondary case. Fine. A week or two passes, and in our clinic, the phone rings. Patient ringing up would like a lower blepharoplasty, and
no,
really wants me to do it. And my manager, who's answered the phone, is thinking, hang on, this name rings a bell. And no, sorry, she hasn't answered the phone. She's next to the receptionist who's answered the phone. And they're going, hang on, just pause, don't commit to anything, and let's get some more information. They start looking up the name. They said, that's the patient that Fulvio gave a report on 2 weeks ago. So this patient is now approaching us and our team to try to get the same surgery, thinking that so there's a lot of the psychological comorbidity. That part of that is concealing it from you. So the very patients we shouldn't be operating on are the ones that try to slip through.
And I was going to say, I'm conscious that I've taken up nearly an hour of your time, but I wondered if anyone had any last burning questions for Fulvio. I could keep you here all day, Fulvio, but I know you've got things to do.
You're really well. I love it. So please cut me off as well if I'm going too far.
Oh, you're not at all. You're not at all. But we've got just a couple of minutes if anyone has any burning questions or wants to ask Fulvio anything. If not, then you can contact us after and let us know. But it's so helpful to talk about these cases with you, Fulvio, because I think particularly for all of us dealing with this, it's definitely more of a challenge in this sort of case rather than a domestic clinical negligence case, because we're looking at different standards of care. So we may find that we may have some report that says, of course, that what happened there was of a different standard that was acceptable in that country compared to here. And often we have issues with medical records and consent and the like. So it's just really helpful to talk it through and understand from your perspective what the burning issues are really, because they're not easy to navigate.
No, not at all. No, I find the lack of records for me in terms of preparing a report one of the hardest and most frustrating things, actually. When it comes to the standard of care, you can talk about the pre-op process and post-op, but effectively, actually what happened during the surgery is often a bit of a mystery.
Yeah, that's definitely the big problem I have when I look through these things. You may not have hardly anything documented, and if it is, it post-dates the event, so you don't quite know what was going on at the time because someone's completed it later, is what I often find. And getting to the bottom of that can be a real nightmare. But I think, given that we've been an hour, I want to thank you so much for joining us. It was brilliant to hear from you. I really appreciate you taking the time to talk to all of us. And thank you, everyone, for watching. There will be a video that's sent around of this afterwards to you, so you can watch us back to your heart's content. And if you have any questions, then obviously don't hesitate to get in touch.
Oh, wonderful.
Thank you so much. Thank you. Lovely to see you.